Okay. All right. I will just keep us moving here. So I have been tasked with speaking about Fontans and the complications associated with those. Dr. Young outlined how we have this wide variety of patients with single ventricles, and we have single left ventricles and single right ventricles, and ventricles that have undefined morphology, and we have this system of palliation, and they will often get a first stage surgery, second stage usually a Glenn, and then the third stage of palliation is the Fontan. The Fontan surgery consists of diverting systemic venous return, the IVC return, to the pulmonary arteries. The kind of key point with the Fontan circulation is that this is the flow to the lungs is passive. There's no ventricular pump directing the systemic venous return to the lungs. This circulation is dependent on low pulmonary vascular resistance, so how we manage things in childhood prior to the Fontan are important. These patients tend to do better at low altitude because of the issues with pulmonary vascular resistance. There's been some evolution of Fontan palliation. This started in the early 70s. The first surgery, the first palliation, was more of a direct atriopulmonary connection, where the right atrium was directly connected to the pulmonary artery. Then there have been other versions of the Fontan over time. The APC connection resulted in a dilated right atrium. It was a very inefficient system. There were complications of atrial arrhythmias and atrial thrombus, and this evolved. This is just an example of the atriopulmonary connection, where the right atrium has been directly connected, usually the right atrial appendage, to the pulmonary arteries. Often in these cases, there had not been a preceding Glenn. Sometimes there is. And then so the IVC and the SVC return is to this large dilated atrium and then to the lungs. But because of the complications of that type of repair, there was some evolution, and that developed into a lateral tunnel and the extracardiac conduit. These days, typically one of those two versions is done. With the lateral tunnel, there's a patch placed inside the atrium, which then creates a tunnel channeling the IVC return to the pulmonary artery. The extracardiac conduit is a synthetic tube, which is sewn directly to the top of the IVC, connected to the pulmonary artery, routing the systemic venous return outside the heart. Both of these provide more streamlined shunting of the IVC return and preservation of kinetic energy. These are both often performed with the fenestration, which is a connection between the Fontan circuit and the atrium. This provides a pop-off. Those patients do better after surgery. There's improved preload at the cost of lower saturations. This is just a picture of a lateral tunnel. There's been a layer of material which is isolating a portion of the atrium still using the lateral wall of the atrium, and that flows directed up to the pulmonary artery. A fenestration would be a hole in that connection. And then an extracardiac conduit is just channeling the IVC return around the heart, and you can make a fenestration connecting that to the atrium and then directing that to the pulmonary artery. And there's been a theme, I think, of tidal wave through the day. and I think more so than any other. One of the things I think about as I take care of adults is this, I also do take care of children, is this flood of single ventricles, and not just, and a lot of the older single ventricles were, that have survived to adulthood were single left ventricles, but now because of improvements in how we do things, there is now and will grow in the future patients with systemic right ventricles or undefined ventricles that are reaching adulthood. There will be fewer and fewer of the direct atriopulmonary connections with time. So a lot of those have been converted to the CCPC connection. The Fontan circulation is a unique physiologic state. It has a variety of sequelae. There are high systemic venous pressures. There are other components of the heart that are important. What's the ventricular morphology? What's the function? AV valve regurg, alpha tract obstruction, all of those are important considerations on how the patients will do. There's a long list of complications of the Fontan circulation. I'm going to try to get through some of the more common ones. The arrhythmias are common. Fontan hepatopathy, also called Fontan-associated liver disease. Protein-losing enteropathy. There are lymphatic abnormalities, chronic venous insufficiency, and ventricular dysfunction. Arrhythmias are common are more atrial arrhythmias, sinus node dysfunction, atrial tachyarrhythmias, and then later in the course, if there's ventricular dysfunction, then ventricular arrhythmias can become an issue. Sinus node dysfunction is common. Maybe it's probably more common in the atrial-pulmonary connection. The sinus node dysfunction is a result of atrial stretch and scarring. If you require pacing, that will need to be usually will need to be an epicardial system with an abdominal generator, and it's fairly common with the atrial pulmonary connection and with the total caval pulmonary connection. If there's conversion, then they often get a Mays procedure, and sinus node dysfunction is common after that, and pacing is often required. As there's been a transition to the total caval pulmonary connection, the incidence of sinus node dysfunction may decrease, and this may be less of an issue as we go forward. Atrial arrhythmias are common. Atrial fibrillation, forms of flutter, ART. This is also a result of atrial stretch and surgical atriotomy and scarring. These patients will often require antiarrhythmic therapy. Catheter ablation is an option, although access to the pulmonary venous atrium can be difficult. If you have a fenestration, then there's ready access, but sometimes you need to cross that baffle to do ablation therapy. And then if there's a conversion, then we'll often we'll try to do a surgical Mays, particularly if the arrhythmias have been an issue. Less common, more related to ventricular dysfunction as these patients get older. If you need to resort to an ICD, that usually needs to be epicardial. The subcutaneous ICDs are a good solution for that as well. Fontan hepatopathy is becoming increasingly recognized in recent years. The liver injury, there can, even prior to the Fontan, there can be liver injury. Just the natural and surgical history of single ventricles plays a role. It can be injury with surgeries prior to the Fontan or at the time of Fontan. because in the Fontan circuit, the systemic venous pressure is elevated. There is a limited preload for the systemic ventricle. This gives low stroke volume and decreased cardiac output. There's chronic venous congestion, which is combined with low cardiac output, induces hypoxic stress and injury, which then triggers inflammation, fibrosis, and potentially cirrhosis in the liver. The progressive cirrhosis leads to an increased risk of hepatocellular carcinoma. By adulthood, almost 100% of patients will have a degree of hepatic fibrosis. And how we screen for Fontan-associated liver disease continues to evolve. Initially, hepatic function is fairly well preserved. Lab testing has limited value. Sometimes there's elevation of GGT. Unclear if AFP is helpful as far as screening for hepatocellular carcinoma in these patients. It's probably best once it's discovered to follow that issue. To screen for Fontan hepatopathy, we'll often start with hepatic ultrasound, can use elastography to check for fibrosis, and if there are abnormalities, then we may start to follow those patients with CT and MRI. A lot of these patients are paced, so MRI can sometimes not be available. The role of liver biopsy is evolving. For a while, we talked about everybody having getting a liver biopsy with a Fontan, but the liver disease is heterogeneous. You do a liver biopsy, you may hit a section of the liver that's pretty good, and miss an area that's more damaged. So liver biopsy may be more focused on defining lesions if you find them with imaging. The Fontan hepatopathy has implications if you're considering heart transplant. Is the liver going to fail with surgery? Hepatopathy improves in some cases after transplant. Dual organ transplant is considered, but it's actually fairly rare that's done. It's important to rule out other causes of fibrosis or cirrhosis. These patients have had blood transfusions. Make sure they don't have hepatitis C. Counsel on limiting alcohol intake. Protein losing enteropathy is seen with Fontan patients. This generally is a result of loss of serum proteins from the GI tract. Affects estimated 4 to 10% of Fontan patients. Has a variable mortality depending on the study. These patients usually present with ascites, edema, sometimes diarrhea. This diagnosed with low albumin, low IgG, elevated stool alpha-1 antitrypsin, lymphopenia. The cause of PLE is still being worked out. We know some things. There's elevated central venous pressure. Lymphatic obstruction plays a role. There is intestinal mucosal inflammation, which results in leaking of proteins. There can be molecular changes in the intestinal cell wall that results in increased permeability. Treatment involves addressing any underlying hemodynamic abnormalities. If there's Fontan circuit obstruction, addressing that. If there is alveolar tract obstruction from the ventricles, addressing that. If there's valve regurgitation, considering doing something about that. Address any rhythm abnormalities, sinus node dysfunction or atrial arrhythmias. Treatment involves a high-fat, low-protein diet, medium-chain triglycerides. Medical therapy includes budesonide, which is a steroid to decrease gut inflammation, heparin or octreotide. If you have a patient with PLE and they're elevated Fontan pressures, we consider sometimes doing a Fontan fenestration if it's not there already, or utilizing pulmonary vasodilators, which are being used more frequently in single ventricle patients. If there's consider also other medical therapy if there is issues with ventricular function. Lymphatics play a big role in the complications of the Fontan circulation. The lymphatics get involved because there's increased central venous pressure. The thoracic duct drains into the systemic veins. The damage to there can be damage to lymphatic vessels at the time of surgery or interventions. Lymphatics play a role in protein-losing enteropathy. They play a role in fairly direct role in plastic bronchitis. There is protein leaking to the bronchial spaces, and then the patients form bronchial casts in their lungs. The lower extremity edema is a common issue with these patients, and lymphedema is part of that. There have been some recently evolving techniques for occluding or dilating lymphatic channels that are promising in addressing some of these issues. These are just some casts, protein casts that patients have coughed up who have plastic bronchitis. Venous insufficiency is very common in the Fontan circulation. About 60% of Fontan patients will have some physical sign of venous insufficiency, and it's severe in about 20%. This is caused by elevated venous pressures. Lymphedema probably plays a role. They've all had frequent catheterizations and trauma to their femoral venous vessels. DVTs because of static flow or venous stasis may contribute as well. Ventricular dysfunction is seen in Fontan patients, can be systolic or diastolic. Causes ventricular morphology is an important consideration. A single left ventricle is going to do much better than a single right in the long term, and the single right ventricles, the hypoplastic left heart syndrome patients are now just starting to get into adulthood, and there's there's the first cohorts in their 20s now, and so we'll be seeing more of those patients. Outflow tract obstruction or valve regurgitation plays a role here. They've had multiple surgeries, and the cost of bypass on ventricular function. Chronic arrhythmias play a role. Chronic pacing can influence long-term ventricular function. It's good to monitor and treat systemic hypertension. Coronary insufficiency can play a role, in particular in the hypoplastic left heart patients who have potential for coronary insufficiency, and then limited preload. The treatment of ventricular dysfunction is, address the hemodynamic issues that I mentioned, maintain sinus rhythm and AV synchrony, treat the tachyarrhythmias if present. There's a variety of medical therapies that we'll use, although ACE inhibitors and beta blockers and ARBs, we use them, but they're role has yet to be proven as if they're beneficial. And then we'll need to go to cardiac, some of these patients will need to go to cardiac transplant. Just to talk briefly about transplant, as a potential option for single ventricle patients, some of the complications of Fontan circulation appear to improve. There is, these patients have had the risk, there's a risk of transplant, including the fact they've had multiple surgeries. There's redo surgery, it's a redo surgery, they have scarring, they may be sensitized. We need to consider multiple organ transplant if that's necessary, liver, kidney. Changes that have occurred in adult heart allocation policies are going to make it more difficult for single ventricle patients to receive transplants in the future. That may be something we want to look into more as far as advocating for our patients. To summarize, increasing numbers of Fontan patients reaching adulthood, understanding the history and evolution of surgical palliation is important. This is a unique physiologic state and disease process. There are many complications related to the Fontan circulation, and there are others that I didn't mention today. The sinus node dysfunction and atrial arrhythmias are common. Hepatopathy is universal. PLE is a serious complication. Lymphatic abnormalities play a role. Cardiac transplant's an option, but may prove more difficult in the future. All right. Thank you.
Hey, thank you so much, Dr. Johnson.